So very good morning, everyone, and welcome to the National Symposium on Diabetic Retinopathy. We have some exciting topics and some very well-renowned speakers that we're going to listen to. So the first one that we're going to start off with is on epidemiology and role of AI in diabetic retinopathy. Our esteemed speaker is Dr. Rajiv Raman, Senior Consultant at Sankara Nethralaya in Chennai. He also heads the Diabetic Retinopathy project at Sankara Nethralaya. So,
thank you. Thanks for including me in this symposium. It's really, every year I think one national symposium on diabetic retinopathy happens. So next couple of minutes I'll be talking about epidemiology. Both topics are a bit different, but I thought I'll combine both to cover in this epidemiology and role of AI in diabetic retinopathy. So let's start with epidemiology, and definitely diabetes is an epidemic. It's a global epidemic today. And International Diabetes Federation did say that the number of people with diabetes more than 20 years, 2045, every 8th person will have diabetes. And the worst part is that 1 in 2 really don't know that they have diabetes. That means there is an equal or more burden of pre-diabetes in the country. And these are the top 10 countries where we have maximum people with diabetes in the world. And combined China, India, and US, nearly half the people of diabetes reside in these 3 countries. So this definitely shows that diabetes is an important problem. Last year we had this, the INDIAB study, the National Prevalence of Diabetes and Pre-Diabetes, and we do have today about 101 million people with diabetes and nearly 136 million people with pre-diabetes today in our country. And they also found that there is something called as epidemiological transition in diabetes, which is seen. That is, the people who are living in the economical developed states, in the lower socioeconomic status, unlike previously we used to believe that diabetes is a disease of higher socioeconomic status. Now in these developed states, it is in lower socioeconomic, and surprisingly, even in less developed states, you still have diabetes, urban, rural, nearly equal, more in the higher socioeconomic status. Very recently, we conducted this multicentric nationwide study called a Smart India study, and a lot of evidences today I'll be sharing is from this study. And one thing which came out is that prevalence of undiagnosed diabetes seems to be equal, both urban and rural area, about 6%. And what was surprising that nearly 75% of people had a suboptimal glucose control. And worse was that HbA1c more than 9, 40% of them had. That means there is a real big burden of uncontrolled diabetes in India too. We came out with this publication on prevalence of diabetic retinopathy, the national prevalence of diabetic retinopathy. I'll share a small video which gives the key messages from this paper. Urban problem, where both rural and urban area having equal. We came out with some priority areas that you need to screen. You need to do a differential screening. We have to prioritize the states where we really want to work more. We identified people more than known diabetes, people more than 40 years, both urban and rural areas should be covered. And today we have a staggering 3 million people more than 40 years with vision-threatening retinopathy. So this study came out with some very hard facts which we need to really think of when we think about our country. And more recently, last couple of weeks back, we came out with this national prevalence of visual impairment and blindness because of in people with diabetes. And again, 1 in 5 diabetes per person suffering from diabetes has visual impairment. Now that's again really very big number. And the higher prevalence of visual impairment is because of in those who have ungradable images. Again, meaning cataract still continues to be one of the leading cause of visual impairment in people with diabetes. And we did find that in gradable images, people with diabetic retinopathy seems to be important, especially people with known diabetes. And socioeconomic status also came out as one of the risk factor. The lower socioeconomic people had more visual impairment. We also went ahead calculating the cost of blindness and visual impairment in India. And again, staggering numbers. I would just draw your attention to the lost economic activity. That's nearly 5 times the health budget of our country. So definitely diabetic retinopathy becomes an important disease which we need to tackle. One thing which again we found, though we had diagnosed so many people with retinopathy, only 10% of vision threatening retinopathy actually took the treatment. So this was really surprising, because this study, we did treatment free of cost. We gave everything, but still 10% came, and this prompted us to try to look at what is the treatment seeking behavior regarding diabetic retinopathy. So definitely it is very poor, and there's poor understanding of diabetes and eye. There's definitely one factor they say is to one treatment may be free, but later we have to pay some cost and prohibitive cost. And we took the ophthalmologist perspective also, and we found some of the barriers there too. So we need to change this treatment seeking behavior regarding retinopathy. This just to summarize. I'm not going into individual epidemiological risk factors, but summarizing the lessons we have learned and what can be the possible policy implication. So as I told you, 75% of the people have suboptimal control, and definitely we need to address this in some way. 1 in 5 people have visual impairment, and we have so many of people blind, and we need to now still prioritize cataract surgery. That is important, because cataract comes out to be one of the leading cause of visual impairment, even people with diabetes. The prevalence of vision-threatening retinopathy is about 4%, and we have 3 million people of vision-threatening retinopathy. We really don't have so many doctors screening and treating. This is an urgent need to identify and treat across the country. There is heterogeneity in distribution, so definitely we need to prioritize the diabetic retinopathy pathways in the states. Again, differentiating it into high epidemiological transition zones and the lower ones. It is both urban and rural. More than 40 years, people should be screened for diabetic retinopathy. And again, it is more common in people with known diabetes. As I told you, it's only 6% prevalence in newly diagnosed. So if we target for screening people who are already having diabetes, I think that will go a long way. This I have already told. And one exciting thing we did in this study, all these images we also used AI to screen. And we saw that the performance of, so the first grading was done at 3 levels. So we had 3 graders grading, and then we also had an AI grading, and the performance of both was nearly same. So we suggested that a physician-based DR screening, AI integration can scale up the screening really in our country. Targeted mydriasis or an AI-assisted prediction of gradability, that also we proved that if we can say that the image would be non-gradable, and we ask the technician to retake the image, the chance of a gradable image significantly improves. And only 10% were compliant. That again attests the fact that we need greater health literacy around diabetes, diabetic retinopathy, and sight-threatening retinopathy. Coming to the risk factors, there are a couple of risk factors which are modifiable and non-modifiable. And we went ahead looking at all the risk factors in South Indian population. So we looked into SN Reams, the Madras Diabetic Retinopathy Study of MV Diabetes, the Arvind Comprehensive Eye Study. We collated all these 3 data and came out with a machine learning algorithm which could rank the risk factors. So we had cures, SN Reams, ATRES, and SN Reams 2. And then we used machine learning techniques to rank these risk factors at the level of importance. And we came out with the AI algorithm that just putting these risk factors because it's next to impossible to screen 106 million people with diabetes in our country. Probably a staged approach using risk factor, and those who are at more risk, doing a screening from them is a solution at the community level. Coming to just concluding the role of AI in diabetic retinopathy. So we have now some established role of AI. Definitely AI-based diabetic retinopathy screening is something which is now attested by not only VRSI, AIOS, even recently by RSSDI and American Diabetic Association. So this is something which should be used so that we can screen more people with diabetes with existing manpower. The risk factor engine for diabetic retinopathy is something which is very important for a country like ours, where the load of people with diabetes is very high. If we can triage the non-gradable images, because using non-mydriatic cameras, nearly 30% of the images are non-gradable. If we can triage them and try to improve this to some level is something which AI has been doing now. Diagnosing diabetic macular edema on OCT is again something which is it has been already established. And Professor Ursula has also tried looking at various fluids compartments in diabetic macular edema with a greater success. She worked on AMD and DR both, and that's also something which is already available. There are emerging role of AI in diabetic retinopathy care, predicting thicknesses from retinal images, identifying imaging biomarkers. People are trying to identify various other systemic disease to some success, identifying the treatment response after anti-VEGF or a steroid, and can we predict the progression of diabetic retinopathy is something which has really worked out, and probably we'll see this sooner than all others. This is the very recent work which was led by Professor Tin Wong, and we were happy to be part of it, where we made a deep learning algorithm which can predict the time to progression of diabetic retinopathy. So I would encourage you all should read. You'll see some images with no retinopathy at baseline. AI predicted even the location where the microaneurysm will develop, and after 4 years we had microaneurysms in that area. So this, we can classify people into high and low risk of progression. Not go in detail, but newer networks were used as far as AI is concerned. The techniques called as transfer learning was also used. And we had this data where we had patients followed after 4 years, images on both sides, and we could make a differential personalized interval. This is the performance across various external data set, including the Indian data set, all of them showing a very promising result. It also used generative AI at the end so that it could even give advice what the patient should do. That's the last slide. So on our Indian data set, we could increase the screening interval to nearly 32 months. That means if you use this AI one, rather than telling every 1 year, we can call them after every 2.5 years. And the delayed detection rate was only 0.37%. And this could reduce the frequency of screening by nearly 62%. I think we'll get more and more of these algorithms with the newer AI networks, and that will really reduce the work of screening this 101 million people with diabetes. Thank you very much.
Thank you, Rajiv. It's very elegant presentation, and the work you are contributing towards the literature is really commendable. I'm interested in a few things which you have talked about, in that pre-diabetics is really a great burden which we are missing. We cannot detect. What are your suggestions for weeding out all the pre-diabetics?
See, as an ophthalmologist, one good thing is that pre-diabetes, though there are Dr. Raj Lakshmi group from MV Diabetes, they have looked into prevalence of diabetic retinopathy in pre-diabetes. And one good thing is none of them have sight threatening. It only comes with mild type of, or sometimes moderate, not more than that. But from a physician point of view, I think everybody more than 30 years is a potential diabetic. And if a yearly blood test is done, we can, and if there is a strong family history, again, Dr. V. Mohan has this scale, objective scale, where you can put in all the parameters, and that will give whether you have at a high risk of diabetes or low. Using those scales and then doing screening is something which can really pick up these pre-diabetes.
Yeah, and in this SMART study, you observed 75% of suboptimal control, which is very, very dangerous.
It's very dangerous.
What are your suggestions to tackle it?
I think it all boils down to the end. Though we have 4 billion people with sight threatening, only 10% came for treatment. So I think health literacy awareness is something which has to be at heart.
Media. We should use the media for propagation. Okay, thank you very much for that. And now I call upon Dr. Santosh Gopikrishna. He will be sharing his new insights into DME and DR management with biomarkers.
So Dr. Santosh is a consultant at Narayana Nethralaya in the Department of Vitreous Retina, and he has a lot of work on biomarkers. So looking forward to hear what you have to say.
Thank you. Morning. Thank you, Dr. Peish and Dr. AOS for this opportunity. So I'll be, it's a basic sciences talk. I'll try to kind of make it simple. It's basically new insights into the biomarkers, especially I'll be talking about molecular biomarkers, the soluble factors, not the imaging and other biomarkers. So to start with, we need to understand what exactly is a biomarker. Biomarker is a characteristic feature or finding that is measurable, which is predictive of outcome, and it aids in prognosis of the therapeutic response. It's a valuable tool for detecting the early stages of the disease, tracking progression, and monitoring treatment response. So even the needs and the requirements of the biomarkers also have changed over a period of time. You can see that the prognosis is most meaningful if the level is clinically actionable, and biomonitoring is also included in the newer definitions of the biomarkers. So we all know this, what exactly causes diabetic retinopathy and diabetic macular edema: chronic hyperglycemia, oxidative stress, and it starts. Hypoxia, ischemia, and blood-retinal barrier breakdown. It could be either neovascular retinopathy, or it could be diabetic macular edema, which is a vision threatening. So this is again a slide showing what really happens to the blood-retinal barrier. You can see the oxidative stress at the baseline here, and which starts and causes leakage. You can see the blood-retinal barrier breakdown. There could be neovascularization that happens. Ang2 and Ang1, these are the factors that act against each other, and VEGF is the main factor that we know and which has been targeted time and again. This again is a picture that kind of depicts what really happens is in a normal retina and what happens in a diabetic retina, and especially in the endothelial cells. You can see what really goes wrong. There can be immune cell activation, there can be gliosis, there is damage to the vascular basement membrane, altered endothelial mural cell interactions, and especially the impaired neurovascular coupling, which leads to neuropathy. And again, this is again important, not just the inflammatory factors, even the angiogenic factors. There is a complex interplay and balance that needs to be achieved. Once there's a tilt, we obviously know that it goes in for an angiogenesis. In healthy conditions, these are the cytokines, chemokines, and adhesion molecules which are normal. But in diabetic retinopathy, everything shoots up, and the balance is what is important, which kind of leads to vision-threatening diabetic retinopathy. So there are several studies and meta-analysis which have shown that these are the potential ocular biomarkers for diabetic retinopathy. Several others are there, but these are the important ones. And these are potential systemic biomarkers for diabetic retinopathy. So we can check these biomarkers even in blood, as well as aqueous and vitreous, as well as in TS. So this is a slide showing the different inflammatory cytokines, the chemokines, adhesion molecules, growth factors. So you can see what all happens in different stages of diabetic retinopathy. You can see the progression. Some are linked to the NPDR and increased with DR progression, but the basic things are the TNF-alpha and the interleukins that starts the process, and from there it picks up and it goes into a complex cascade. So these are the different mechanism-based treatments. So when you give a steroid, everything kind of comes down, all the inflammatory biomarkers, even the VEGF to some extent. But when you look at the TNF-alpha and all, these are the molecules that are being explored. Some are kind of terminated because of there was not proper response, and some the research is still on. So if you look at previous papers, they showed that inflammatory biomarkers like IL-6 and VEGFs are obviously elevated, And when you have an ICAM, which is there earlier, it gives a protective role. So that is what the earlier papers have told. Now, if you see this paper, it shows that not only VEGF, we need to look beyond VEGF. So there is an extra VEGF cascade that happens, and which needs to be targeted for better treatment. So even the ICAM molecules correlates with the disease severity, especially in recurring macular edema. So this is an old paper which shows IL-6 and IL-8 are increased in different types of macular edema. You can see a cystoid or a mixed macular edema, and these two things are elevated. So this is work done by Rajiv Raman sir. So they find that IL-1 RA is elevated, and you could see the potential increase in this biomarker over the severity of diabetic retinopathy. Then again, soluble CD4 counts in aqueous humor are elevated when you see these HRDs in diabetic macular edema. And these are the newer papers which again reiterate the same thing, saying that these biomarkers are extremely important and these need to be targeted. You can see these 6 biomarkers that are mentioned here, including VEGF, ICAM and all, which kind of play an important role in diabetic macular edema and diabetic retinopathy. So these are the molecular signatures and approved agents. If you look at across neovascular AMD, DME, PDR and RVO, so these are the molecular signatures that can be targeted, and these are the FDA approved agents across these diseases. Angiogenesis is an important part. There are multiple targets that could be achieved, but it's not necessarily that they'll kind of reach a viable endpoint. So it's a different ball game, and it's difficult to kind of get a potential therapeutic target in such cases. So these are the ones which are approved drugs. These are under research. You can see many are in phase 2, phase 3 studies, and most of them target VEGF, some target Ang2, and there are other molecules also that are being targeted. So ultimately, the reliability and the end product is what is important. So coming to a sneak peek into what's really happening at Narayan Nethralaya. So we actually have this project strategy wherein we look at aqueous humor. We look at the profiling, we see at the severity of diabetic retinopathy, types of diabetic macular edema, and the treatment outcomes, especially if it's a treatment naive case or recurring or non-responding diabetic macular edema. And then we even check these samples across in comparison with the controls as well as in PDR cases, especially vitreous hemorrhage. And then it comes to in vitro trials, wherein we kind of see these factors and check how they react with other molecules, anti-VEGFs and TNF and all. So these are on RPE cell lines or HUVEC cell lines, and in vivo, especially the mice models. So this is the samples type and strategy, how we go about. We collect these, and they're stored at -80, and CBA analysis is done. Around 50 changed biomarkers are usually done. And there was a positive association that was established long back in our lab between the aqueous as well as vitreous. And if you look at different types of macular edema, you can see the various factors are there, but these are little difficult to interpret and kind of come to a conclusion because statistical analysis is not very easy. There are multiple factors involved. So to come out, we can publish a paper saying that these are so and so, but to have a statistical analysis, it's a little extremely important to have large data. This is again across severity of diabetic retinopathy, non-severe DR, severe DR, and PDR. You can see the complex interplay of these factors again. Now, when it comes to vitreous, you can see a clear change in the biomarkers when it compares to controls. When you have a vitreous hemorrhage and PDR, all these factors are definitely elevated. And again, these are the interplay between aqueous as well as vitreous humors in PDR and normal control cases. ICAM is one molecule which we really kind of found interesting. That is because it's an adhesion molecule, and we have found that it is extremely important in non-responding DME, and somehow like we are proceeding in this lines of finding a more substantial kind of research on this. Then coming to in vitro, so we have these RPE cell lines. You can see the mRNA expression of the ICAM and IL-6. When you have a TNF alpha inflammatory response, the ICAM goes high, even IL-6 goes high. So the mRNA expression and secretions, even later also after 24 hours, it remains high. Then again, this is the same kind of a thing. It shows that inflammatory stimulus induces secretion of ICAM, which is independent of VEGF. So when you kind of subject these RPE cell lines or HUVEC cell lines to inflammatory stimulus like TNF alpha, especially the ICAM goes high, whereas the VEGF remains low. So it definitely means that there is an alternate pathway that is responsible for diabetic retinopathy and diabetic macular edema. This is again a similar kind of thing wherein if you have a increased TNF alpha, you can see fourfold inflammatory stimulus in these conditions. And then again 72 post, especially if you subject these cells to hyperglycemic stress, then again the increase in ICAM is several fold, and you can see the changes in ICAM as well. So this is again kind of reiterating the importance of ICAM when you subject the patients with different combinations of TNF, and you've kind of given VEGF at anti-VEGF and TNF with anti-VEGF. This is how the molecules and the solutes behave. It's the same reiteration, and these are some papers what we have published over a period of time. You can see this S100 and these are the molecules which kind of say that the damage related to molecular proteins, they directly correlate to the severity of diabetic retinopathy. As the severity of diabetic retinopathy increases, these moleculars are found in excess. This is again a different lens protein that is expressed in astrocytes. So when the expression is more, especially in PDR, if you see, there is a lower level of these astrocytes in vitreous. So decorin is a small leucine-rich proteoglycan. It's a part of retinal endothelial ECM. These elevated levels are seen in severe DR groups again. STING, this is a newer paper what we published. When it's, this STING is a stimulator of interferon genes. It regulates the cell senescence and inflammation, and it's extremely important for the development and progression of DR. And in mice models, we have seen that targeting STINGs could be an effective treatment strategy for early DR. So this is the newest paper wherein we have seen microRNA from RP cell line. It regulates multiple gene products. So it has an important role in glycolysis and angiogenesis. So RP cells, when they are under high glucose stress, the mRNA is elevated, and this kind of alters the glycolytic pathways, and increased expression of VEGF is noted. So coming to our newest thing, the biomarker pathfinder, we have 8 molecules that could be identified. It's a readout that comes in 2 to 4 hours. So this is how it's done, and the TRs is collected, they put in a buffer, and you can put it in the cartridge here. And once you put it in the machine, you get a readout after 2 to 4 hours, depending on the number of molecules that we read. So we try to look into whether AI can help to understand the complex interplay of these biomarkers. So we had done these 8 biomarkers, and we have taken a cohort of 192 controls and 175 treatment eyes. So what we have seen is there was a good correlation, and the sensitivity and specificity was really good. What AI had found was these 3 biomarkers which were really important, the ICAM, MMP9 and VEGF-A. In some cohorts which didn't have a diabetic retinopathy, we found that the VEGF-A was high, and these we named it as vascular disease suspects.
Santosh, you have to conclude.
Yeah. So the vascular disease suspects were more prone to kind of go in for a diabetic retinopathy and a vision-threatening diabetic retinopathy. I'll just skip these. So VAS study is the newest one. Dr. Chetra had presented recently as a free paper. This is a relationship between immune factors between vitreous, aqueous, serum, and tears. The cluster, if you can see, the cluster 2 has more molecules, and you can say that the correlation is better between vitreous and aqueous. So it definitely means that aqueous can be used as a substitute for vitreous to measure these biomarkers. So to conclude, these are the molecules that are really being considered, anti-angiogenesis, even RAS blockage are being considered. So DR and DME, there's a complex interplay of soluble factors. Pathways are beyond VEGF. R&D, especially once we start targeting these molecules, there could be a personalized treatment, especially like molecules like faricimab. So to conclude, it would be right to say that the ideal biomarker is the one through which the disease comes about, or through which an intervention alters the disease. Thank you so much.
Thank you. Thank you, Dr. Santosh. I think it was a real deep insight into the biomarkers, but I think what's the clinical application as of today?
As of today, we have been finding different pathways of initial starting of diabetic retinopathy. The molecules, especially the cascade which can start diabetic retinopathy. I know it's like, when it translates to translational science, especially the medicine, it's difficult, it's a long way to go. But these are the pathways which could be targeted maybe in the near futures.
Yeah, wonderful presentation and wonderful work you're doing. Thank you.
Thank you, sir.
So I take the opportunity to invite Dr. Kim
how diabetic retinopathy telescreening has improved timely management. He is currently the president of Telemedicine Society of India and also the chief of Retina Arvind Group of Hospitals. Thank you, Ken.
Good morning.
Thank you,
everyone.
Dr.
I
Natarajan.
thank
President
AIOS
of
for
VRSI.
giving me this opportunity to
President of VRSI.
present
Yay.
experience and experience.
At the outset, thank you for inviting me to be a part of this symposium. A topic of importance for all the ophthalmologists. My topic is on how DR telescreening has improved timely management. I'm not sure whether most of my talk is on the diabetic retinopathy screening, not so much on the outcomes, because as Dr. Raji Raman pointed out, I'll come to that part when I say. So we do know that the burden of, I think Rajiv really brought out the epidemiology, the prevalence of diabetes and diabetic retinopathy in our country, which really shows the importance, especially for the retina people, because the amount of problems that we need to manage is so huge. The overall prevalence of diabetic retinopathy from the Smart India study was around 12.5%. And he showed that the vision-threatening diabetic retinopathy above the age of 40 is about 4%, which means we really have a huge problem, and there's no difference between the rural and the urban areas. We all know that the early diagnosis is very important in these patients, and only then you can retain the patient's normal vision forever. So we also know many studies have shown that the patients, and you yourself would experience, when patients come to you with diabetic retinopathy, it's only at the late stage, not at the early stage of diabetic retinopathy. So what should be done? Can only the ophthalmologists screen for all the diabetics for diabetic retinopathy? We have to find other ways, which means the target population of diabetic patients are seen mostly not by the ophthalmologists, but by the general physicians, diabetologists, and endocrinologists. They are the people who have to own the process of identifying, and today that is very much possible that they can screen patients. At Arvind, we have been doing this screening camp for almost 25 years now, 24, since 2000 we have been doing this, going into the community, screening patients, diabetic patients. What happens is we work with the local physicians to identify the diabetic patients from the community, and then we screen those identified patients for diabetic retinopathy, and this has been going on. We continue to do it even today. Every week we continue. This was some data which showed that the new diabetic retinopathy identified in these processes was around 70% in all the patients that we screened. What it means is there are so many people out there who are not identified, who have a normal vision, and every one of us have to take that responsibility of identifying patients, not just finding patients who are walking into our clinic. What is it that we can do beyond this? Because we know that this is an epidemic that is happening of diabetes. How do we ensure that every patient, at least their vision is prevented? As ophthalmologists, we have to do it. The challenges of doing these screening camps, of course, there's a lot of demand on resources. It's not possible for everyone to do it, but where possible, you should screen the patients as much as possible, because here you need the resources like doctors, paramedical team, local facilities, support systems. More importantly, financial burden, because there's no return on investment on this. There's no direct return on investment in the process that you do into the community. So telemedicine seems to be an answer to this problem of creating access, screening patients opportunistically whenever they walk into diabetic clinics or the physicians' clinics. So we've been doing the screening for quite some time now, using telescreening again for the last 20 years, where the diabetologist clinic technicians are trained to use the fundus camera. They take the pictures, send it to the reading center in our hospital. A retina specialist or a trained grader would look at these images, create a report and send it. So only those who have any retinopathy are referred to the ophthalmologist, while the others are asked to come on a yearly checkup. There is some amount of awareness created among the patients in the diabetic patients. The diabetologists also become aware that they have to do this, and then it's definitely a value addition to the service that they do. So again, through these, in 1 year, we were just looking at data, I'm just putting random data, where we showed that the new diabetics retinopathy identified who never had any retinopathy identified or their fundus examined was about 68% in this that one period. We also had ISRO had given us a mobile van. Both Shankar Netralia and Arvind had these mobile telescreening van in the early part of 2000, and somehow it lost because of the technologies that have changed with time. The same process was done. The bus would go, find diabetic clinics and bring their patients into the bus, screen them, and then the process of telescreening was done. And again, the new diabetic retinopathy identified, because this was going into many of the rural communities, and we were able to identify almost 85% new diabetic retinopathy patients. What are the challenges in telescreening? Putting the physician to asking them to make this value addition for their patients, it is still a challenge. Very few people are willing to do that, though they know that this will be a very good the necessity for their diabetic patients. Using a retina specialist time is again a problem, inconsistency in grading, which that Rajiv pointed out. And it takes a period of 2 to 3 hours for this, and it's not available 24/7. So again, Dr. Rajiv showed how AI can help. Just a simple algorithm can grade the diabetic retinopathy within a few seconds and give you the report. And this has been, we have been using this for quite some time since 2019, where we have replaced the AI tool. So the physician, without our help, is able to screen that. And then both of us at Shankar Netralia and Arvind, we have done multiple validation studies using this algorithm to show that this algorithm is comparable or better than a retina specialist. More importantly, it is consistent and available 24/7. So since then, we have deployed this in real time. We have been screening these patients in the last 4 years, and we screened about 700,000 eyes. And we found that the referable DR was around 7%. Referable is any DR which is more than moderate or more than moderate or referred, and any ungradable image becomes a referable DR. Again, this similar process is done at Mohan's Diabetic Center on a regular basis. This is Dr. Rajalakshmi's data, where they also show about sight-threatening retinopathy is 7%. The reason for this is because they are looking at, it's in the diabetic clinics they are doing the screening, which means you have concentrated diabetic patients, not in the general community. So that is the reason the number still happens to be higher at 7.3% in the sight-threatening retinopathy. This is another data that I just looked at before we started using AI versus after using AI. We found the difference for a 1 year period. I looked at it, similar number of patients who were screened. The number of diabetic retinopathy identified was around 1,090, whereas after the deployment of AI, the numbers seem to be very high, almost went about 8 times, which is tremendously very, very high. Are we missing? So we are just looking at analyzing that data at this point of time to see. This was just a few 3 months data that we looked at. So we need to look at a larger number of data. How AI is making such a big difference in identifying, because it even picks out those small microaneurysms which is not normally seen by the human eyes. So it is definitely making a difference in the way we identify these diabetic retinopathy. Now, when you look at the evolution of this whole DR screening program, we have come a long way from doing camps, using mobile vans, to today using it on the spot in the physicians' clinics, using it and opportunistically wherever possible, be it medical labs. We have tried it using it in the labs, wherever the diabetic patients would go to buy medicines, even medical shops. We have run these screening programs and continue to do so in most of the diabetology clinics so that every single diabetic patient is screened. What has made this possible? Of course, the opportunistic screening, available of low-cost fundus cameras, availability of the broadband internet, and deploying a basic fundus camera with AI today helps in identifying this. This is again our own short 3 months data that I looked at how many patients referred and how many patients actually visited the base hospital. If you look at it, it is 70%. Now this, what Rajiv said was around 10% to 70%. I agree with Dr. Rajiv because the 70% is literally pushed in many ways for the patient, facilitating the patient, calling the patient, making sure that they come and visit the hospital was done. Otherwise, it would still remain at 10% because I still have the data where we have not done that. The response is very, very low. This has definitely increased, the telescreening has increased in the country due to improved awareness involving other stakeholders like diabetologists, technology, innovations, availability of low-cost fundus camera. Has this increased the timely management? It is a big question mark. As I said, even upon identifying high-risk patients, securing their cooperation for subsequent follow-up and management is still a big challenge. Lack of awareness among patients and even healthcare workers, including doctors, is still there. Though it has improved, it is still has to be improved in many ways. And of course, as again Rajiv pointed out, the financial burden, unlike cataract, it's not a one-time management. The patient has to continuously follow up. And this, we have to find ways to reach out to these patients and ensure that they get the timely management. So with use of technology today, I think every one of us can easily reach out to these patients. So how do we reach out to those patients who are not walking into your clinic? It is our responsibility as ophthalmologists to ensure that every diabetic's eye is preserved. Thank you, sir.
Thank you very much, Kim. Actually, your Arvind's and Yashan's efforts are really very good. However, what shortage I see is there is no continuous existing facility for the population to avail the facility. Here, if I see your presentation, what I can understand is definitely AI is up the detection by 8 times, which is very commendable. However, if you see the sight threatening, it is 1.4% RPDR, which we can prevent by timely laser. So would you think anything which this society-based facilities or some screening availability? Because today you will go, you will detect and come back. But what will happen to the future?
That's what. Once you you should have some kind of a national program for screening. Ensure every PHC has these facilities. As much as they identify diabetics, they should be able to screen these patients. One, you could do the screening, but we need to ensure that we complete the loop. That means the patient should have a place to go when they have some sight-threatening lesion or even any diabetic retinopathy. They should be able to go and get access to treatment. So these are still lacunae there, but we need to build up on that, sir.
Compliance. It is again, after coaxing it is 70%, otherwise it is 10%.
Yes, definitely it is very, very low.
What will we do for that?
No, we need to create the awareness. It has to increase because people, it is much better than where we started. I think today, if from VRSI, there's a lot of effort that is happening, working with the RSSDI, the Diabetic Association. We are trying to see how to move this screening at the national level using the RSSDI members and creating awareness among those people.
Okay, thank you very much. And now I invite Dr. Manisha Agarwal. She will be speaking on imaging in diagnosis and management. Dr. Manisha is the currently Secretary of Vitreoretina Society and doing a very good job. Dr. Manisha.
Thank you, sir. A very good morning to all of you. Imaging modalities in diabetic retinopathy are of significant utility, all for screening, evaluation, diagnosis, as well as management of diabetic retinopathy. And different imaging techniques can be useful depending on the manifestation or the stage of the DR that we are dealing with. So in our armamentarium, we have color fundus photography, fundus fluorescein angiography, and ultrasound, OCT, and last but not the least, we have optical coherence tomography angiography. So as far as the color fundus photography is concerned, this is very helpful for screening and for documentation of DR, as well as for counseling our patients when they visit our clinics. It is also useful for monitoring the progression of DR. And there are different types of fundus photography which is available. We can have a standard, we can have a wide field, and also now we have the ultra wide field which provides a 200-degree snap in one go. Screening for DR outside the ophthalmic clinics is always a challenge, and I think Dr. Kim really spoke about it. And what we are now targeting is that we should not only limit the screening of DR in ophthalmic clinics, but also target the physicians and the diabetologists. And this can be very well done using the non-mydriatic fundus cameras with AI and also using telemedicine. The advantage being that it is an easier access, a better compliance, as these screenings can be done at primary healthcare provider clinics there itself. And this is a slide I borrowed from Dr. Kim, who Arvind Eye Hospital and SN both are grossly involved with screening of patients for diabetic retinopathy. And as rightly shown, that when we are using tele-screening, the turnaround time can be around 1 hour. But when we are using an AI tool, it can be reduced to as short a time as 1 minute. Coming to fundus fluorescein angiography, we all realize that it's an invasive procedure. However, it still remains the gold standard for managing a patient of diabetic retinopathy. And the indications being that it helps to diagnose proliferative stage of diabetic retinopathy, when we are suspecting macular ischemia, planning macular laser treatment, in patient with asteroid hyalosis, and also for identifying the capillary non-perfusion areas. So though the classical teaching is that we would advocate a laser treatment when the patient has reached a stage of PDR, but many a time these patients may not be able to come back for a regular follow-up. And then the patients with a severe NPDR with extensive CNP areas also can be advised a laser photocoagulation to avoid a sight-threatening stage of DR. This is a wide field angiography, and it reveals much more than a normal angiogram, and you would see that in a normal angiogram, you're able to assess only the central part, but many a times you may have the pathology lying in the far periphery, which is much better picked up on a wide field angio. This is, again, a wide field FFA, which is showing that there are extensive CNP areas and persistent neovascularization, which is in the far periphery, requiring addition of laser photocoagulation. Coming to OCT and its role in DR, it's again a non-invasive test, and so it is very much easily doable in our clinics. It helps in quantitative assessment of diabetic macular edema in the form of assessment of macular thickness. And we can also do a qualitative assessment of DME, whether it's central involving or non-central involving DME, and what's the type of DME that we are dealing with. And also it can help in assessing the response to the treatment and detection of recurrence of macular edema. We have various kinds of OCT biomarkers for DME, and the most common ones that we really assess and have a clinical implication is the epiretinal membrane, neurosensory detachment, DRIL, a DROL, hyperreflective foci, the choroidal thickness, and they all are said to influence our treatment decision, whether we would like to treat our patients with anti-VEGF, steroids, or a surgical intervention. And all these biomarkers, of course, have a role to play when we are wanting to prognosticate our patients. So here we have a thick posterior hyaloid phase, which is causing a traction on the posterior pole of the retina. And here, whatever agent you may try as an intravitreal injection, it's unlikely to have a benefit because all the inflammatory mediators, they tend to collect in between the posterior hyaloid and the retina, and where any pharmacotherapy is unable to really penetrate. And these are the patients who would ultimately require a surgical intervention. There's another term called as disorganization of the inner retinal layers, and this is basically to identify any kind of an ischemic insult to the retina. And this is how we identify a drill while we are doing an OCT, and this corresponds very well to macular ischemia, which is seen on FFA and OCTA. However, what we need to understand and remember is that we have to continue the treatment as it is reversible. It correlates well with the visual acuity and also helps to prognosticate the patient. A drool is a bad prognostic sign because it tells us that there has been a damage to the photoreceptors, and these patients are unlikely to recover the vision. Hyperreflective foci are basically inflammatory cells, and therefore these are the patients who are going to respond better to an intravitreal injection of steroid rather than anti-VEGF. And a subfoveal detachment again tells us that these are patients who are going to be responding better to an intervention with steroids rather than anti-VEGF, and because it signifies a higher collection of inflammatory cytokines in the vitreous. OCTA, on the other side, is again a non-invasive tool, both for qualitative and quantitative assessment of the macula, including macular ischemia. It is able to identify various signs of diabetic retinopathy and also helps us in various metrics assessments such as vessel density, foveal avascular zone, and the areas of non-perfusion. It also helps us to monitor the progression of diabetic retinopathy. Microaneurysms, of course, is a feature of DR, which is basically said to be a slower flow speed pathology, and therefore it is better picked up on a fundus fluorescein angiography rather than on an OCTA. And that is how we need to understand that both FFA and OCTA are going to be complementing each other. IRMA is visualized on NFAS images, and they appear as dilated or looping vessels near the areas of CNP. The caliber of these loops is noticeably greater than that in the surrounding area. We can also image the neovascularization, and it basically is going to be identified by the disruption of the ILM. Flow signals above the ILM will help us to differentiate between NVE and IRMA. The advantage of OCTA is it picks up very subtle NVEs which may not be detected on FFA. It also helps in precise measurement and monitoring of the size of NVE is possible, which is maybe obscured by the leakage on a fundus fluorescein angiography. The disadvantage is that if there are very elevated NVEs beyond the margin of the ILM, they may appear as shadows rather than a flow area. So here, these are a few of my images where you see that on a color fundus photo, you are able to identify NVEs, and on doing an OCTA, again, you are able to pick up the same areas, which beautifully, again, is going to be helping you pick up NVE in a non-invasive manner. This is a comparison between OCTA and FFA, where you can again identify the NVE areas. And this is a patient of asteroid hyalosis, where again on OCTA you can identify the details of the fundus. So OCTA basically helps in monitoring the regression of neovascularization. No changes found in the density of superficial or deep capillary plexus. And this is a color fundus photo, OCTA and FFA, where again pre and post laser you can identify the regression of the new vascularization very beautifully, again, which is very well seen on an OCTA image. This shows the active neovascularization above the ILM, which has shown a beautiful regression again after doing the laser treatment. You can also pick up macular ischemia by enlargement of the foveal avascular zone, and thus you can actually monitor the progression of changes of diabetic retinopathy by a non-invasive tool such as OCTA. The future holds in recognition of subclinical diabetic retinopathy, and OCTA may offer an opportunity to detect DR when subclinical in a non-invasive way, and this may impact our follow-up. And very subtle changes such as decrease in the deep plexus, vessel density, enlargement of FAS, a decrease in the parafoveal vessel density in both superficial and deep vascular layers, and impairment of the choriocapillaris flow may be very subtle changes which can be picked up and helping us in identifying subclinical DR. A wide field OCTA in a patient with no clinically evident diabetic retinopathy again can rarely pick up the changes which are happening in the far periphery. Therefore, to conclude, color fundus photo helps in screening for DR even outside ophthalmic clinics using teleophthalmology and AI-based cameras. Multimodal imaging, including FFA, OCT, and OCTA, helps in evaluation, prognostication, and management of DR. Wide field imaging may help in identifying the peripheral retina changes and early diagnosis of DR. And OCTA may help us in future to pick up subclinical changes of diabetic retinopathy. Thank you so much.
Thank you, ma'am. Due to paucity of time, we'll move on to the next speaker. The next talk was evidence and experience in medical management of DME and DR. It was supposed to be given by Dr. Rajanarayanan. Now, Dr. Rajanarayanan is the head of clinical research at LVPI and senior consultant in the Department of Retina in Anant Bajaj Retina Institute. Now, he was unfortunately not able to come, so we have a recorded presentation which we will now play because it's an important topic. The number of people practicing medical retina is increasing day by day.
Good morning, everyone. I thank AIOS for giving me this opportunity to present on evidence and experience in medical management of DME. We all know there are numerous anti-VEGF agents available for the management of diabetic macular edema, starting from pegaptinib to bevacizumab, and then we had ranibizumab, aflibercept, and recently we have brolucizumab and perisumab. So with all these molecules of just anti-VEGF, and other than this, we also have steroids which are approved for management of DME. It can sometimes be confusing as to which agent to choose for the management of diabetic macular edema. There are numerous studies which have compared these anti-VEGF agents, and there is also one study on the pivotal study of DEX implant, and also comparative studies of steroids and anti-VEGF agents. But we probably won't go through all the studies, and it's not easy to remember all the study details. But the point about these studies is we should at least know what agent is good or most effective in terms of both visual acuity as well as drying of macular edema. And if we have to choose between two drugs, is there any evidence to show that one is better than the other? One of the first studies, which was a comparative study between ranibizumab and actually triamcinolone acetonide, with or without laser, the protocol I study of DRCR, at the 5 years of follow-up showed that the mean visual acuity gain in eyes who received ranibizumab injections with deferred laser, or you may call it as only anti-VEGF agents for most of them, the mean improvement was about 10 letters. 10 letters is about 2 lines. Let's say 2 lines means 624 to 612 or 618 to 69 in general. And if you see the eyes, if you subdivide them into eyes with better vision at baseline, that is to start off with. So those eyes which had 20/50 or better vision at baseline, they gained approximately 5 letters. If you see this graph, it's the y-axis is number of letters. So 5 letters is 1 line. You see that the previous slide which I showed, here it showed 10 letters overall, that is 2 lines. But if a patient has good vision at baseline, they gain 1 line. So it's kind of counterintuitive if someone believes that those who have good vision at baseline will improve more. The point is that those who have good vision at baseline improve less, but since they were already good to start off with, they still remain good. Protocol T was a comparative trial between aflibercept, that is Eylea, bevacizumab or Avastin, and ranibizumab or Lucentis/Excentrix. And this was a very important study. For most of the last decade, we had only these three anti-VEGF agents. So again, in protocol T, what it showed that eyes which had worse than 20/50 vision, similar to protocol I, they gained much better vision. Means both aflibercept and ranibizumab are quite similar to each other, but the red line, which is bevacizumab, had very less gain in vision compared to aflibercept or ranibizumab. But if you have a baseline vision of 20/50 or better, now in these eyes, all three injections performed very similarly. So one take home could be that if you have a patient who has early vision loss due to DME, you probably can start off with any of these injections. There appears to be not much of a difference between the three injections. But in terms of OCT outcomes, aflibercept had the best drying effect compared to ranibizumab or bevacizumab. So in protocol T, the retreatment criteria were more strict in the first 6 months. Any edema you have to treat, unless the patient is 20/20 and dry. But if the patient has completed 6 months, you can hold off on the injections even if there is edema. So if the edema is stable and the vision is stable, you may choose to not inject in these patients. The number of injections in protocol T was about 15 injections in 2 years. Faricimab is the new drug which was launched in India in January, and Yosemite and Rhine trials were the main trials for DME, and it showed that patients with faricimab treated with 8 weeks or even PTI regimen of 12 to 16 weeks, they showed equivalent results to aflibercept or Eylea, and many patients could be maintained at 16 weekly intervals, that is 4 monthly injections. If a patient has very good vision at baseline, you can choose to even observe them as shown in protocol V. You don't have to inject all patients with edema if they have 20/25 or good, better vision, as this study of protocol V showed. So the Indian guidelines published by Dr. T.P. Das et al. Recommends that anti-VEGF should be the first line of treatment in central involved DME, and laser can be a first line for non-central DME or even central DME with good vision. And surgery for VMT and ERM should be considered. I would just like to present one case, cataract surgery done in both eyes earlier and was diagnosed with non-proliferative diabetic retinopathy with CSME, had received already injections, Avastin and Ozurdex before she came to us. She was 20/100 in the right eye and 20/40 in the left eye. The left eye showed neovascularization with extensive capillary non-perfusion. OCT showed a large CME with some intraretinal hyperreflective dots, some discontinuity of the ellipsoid zone and external limiting membrane. There was intraretinal cystic hyperreflective material in the left eye, which is again not a very good prognostic indicator. A lot of high reflective dots in the left eye. And this patient's blood pressure was 200/100 millimeters of mercury, was restarted on antihypertensive. So the point is you have to systemically evaluate these patients. This patient was advised ranibizumab injection in both eyes and also pan-retinal photocoagulation in both eyes. The edema did subside with some improvement in vision in both the eyes. The inset is the baseline. But I'll now skip to the overall treatment how many injections this patient received. The point is that this patient had recurrence of macular edema repeatedly, and the patient had to be given multiple ranibizumab injections, but then was switched to brolucizumab last year. And with brolucizumab, there was a better drying effect, although the visual acuity did not improve much. But, and this is the left eye, but in spite of that, this patient had recurrence of edema after 3 months. So with brolucizumab also there can be recurrence, obviously, but these patients require less frequent injections. And with brolucizumab, the macula more or less used to dry, and the patient has been maintained on brolucizumab injections with stable vision. So in conclusion, DME, we typically start with anti-VEGF injections. We switch in about 2 to 3 injections. Steroids are used for maintenance for the most part. Very rarely steroids may be used as first line, like patients with stroke or heart disease recent, or if they are already pseudophakic with good vision. And edema is a very important biomarker, and it's very simple determinant of treatment decisions. And I also would urge that everyone should get trained in injections before they start giving injections.
Since he's recorded this thing, we will not ask any questions, and without wasting much time, I request Dr. Mahesh Shanmugam. Probably he's the best one to speak on surgical management of proliferative diabetic retinopathy. Currently, Mahesh Shanmugam is the chairman scientific committee with the Retina Society, and he is the founder of RetNet India.
Thanks, Dr. Ajit. This talk is on surgical pearls and diabetic vitrectomy. So let's start with the indications of diabetic vitrectomy. Of course, like we don't want to do a vitrectomy in diabetics. If in case like Dr. Kim and Dr. Manisha and others have their way, we will not be doing a diabetic vitrectomy at all if we screen them in time. But then we do get a significant number of diabetics for vitrectomy. The traditional indications are non-clearing vitreous hemorrhage, traction retinal detachment involving the macula, and combined retinal detachment even if the macula is not involved. Because combined retinal detachment is like a recommended retinal detachment. It's a macula-on detachment, we still go ahead with the surgery. Earlier teaching used to be that we wait for 3 months, waiting to see if the vitreous hemorrhage clears, and if not, we do surgery, but then we don't wait for 3 months anymore. It has been shown that early surgery, particularly in type 1 diabetic, yields better results. And if there are no contraindications, I would wait until a month. Contraindication in the sense, if there's no secondary glaucoma, or if there's no traction retinal detachment on an ultrasound, I would wait for a month. If it doesn't clear, we'll go ahead with the surgery. Now let's start with point number 1. Indications have expanded as far as diabetic vitrectomy is concerned. Even if there is an epiretinal membrane which is causing macular distortion and a cystoid edema, then we go ahead with the surgery. So this is a slide which you did see earlier in one of the presentations. So proliferative diabetic retinopathy with a thickened posterior hyaloid, which is resulting in diabetic macular edema, is not going to resolve with injections and needs a vitrectomy. So this is how we go about doing a vitrectomy. You can hardly see an epiretinal membrane, but then we do a vitrectomy, induce the posterior hyaloid, and then once we are able to peel, induce one small nick in that epiretinal membrane, you can see such an extensive epiretinal membrane which is invisible was there. Then nowadays we do go ahead peeling the internal limiting membrane so that they decrease the risk of a secondary membrane formation, as well as the macular edema results better if you were to peel the epiretinal membrane, but the internal limiting membrane. But of course we have to be careful not to deroof the cystoid edema. Another indication would be a vitreopapillary traction. This is a ill-defined entity in the sense that the traction is on the disc. So you may see a disc edema because the posterior hyaloid is pulling on the disc. So here we peel the hyaloid from the disc, then the stasis in the disc decreases and these patients improve in vision. So here you do have an epiretinal membrane as well as traction on the disc. So not that we jump in and do surgery in these patients, we look for a disc edema as well as we do a serial VEP to see if the VEP is subnormal, or if there is a progression of vision loss, then we go ahead doing a surgery. So this is how things can be. It looks like as though there is no epiretinal membrane at all, but there is actually a taut posterior hyaloid which is causing this extensive exudation. And post-vitrectomy, you can see how well the exudates improve and the patient's vision improves. Asteroid hyalosis, which precludes a PRP, is also an indication for doing vitrectomy, so that we're able to do the laser photocoagulation, which the asteroid is preventing it from. Other indications are dense premacular hemorrhage, hemolytic glaucoma, recurrent vitreous hemorrhage, and antihyaloid proliferation. Pearl number 3 is if there is an extramacular traction retinal detachment. As you can see, the detachment is here and the fovea is spared. Best is to watch, because this is an extremely difficult surgery and there is a possibility that this patient will lose vision following surgery. Wait to see if there is progression and decrease in vision before we operate. So what is the risk if we decide to wait? So risk of macular involvement in extramacular traction retinal detachment, as you can see, is about 14%. And the larger the size of the extramacular traction retinal detachment, more is the risk that it may progress. So larger the size of extramacular detachment, we tend to follow these patients much more closely to see if it moves towards the macula. So what is the role of anti-VEGF? Yes, it eases out the surgery quite well. So it decreases the risk of bleeding and the surgical process is much better. But then we have to operate within about 3 to 5 days after injection. Otherwise, there is a possibility of this detachment worsening rapidly and becoming a combined retinal detachment as well. I don't use them in all the cases, and anti-VEGF can be used at the end of the surgery, and studies have shown that the recurrent vitreous hemorrhage after a diabetic vitrectomy is much lesser if we leave the eye with an anti-VEGF agent. Disadvantage is it adds to the cost, and we still don't know if these anti-VEGF agents add a systemic risk factor like cardiovascular events or CNS events. So that's something which is not clear as well. Moving on to vitrectomy and proliferative diabetic retinopathy, one of the pearls for the budding surgeons is more fundus details we are able to see, more difficult the surgery. That means there's no hyaloid separation. Hyaloid separation induces vitreous hemorrhage, which is not there, then more difficult the surgery. But on the other hand, if there is vitreous hemorrhage or subhyaloid hemorrhage, then that means large amount of the hyaloid is separated, so it's easy to do the surgery. So the steps is do a core vitrectomy, then make an opening somewhere, and then drain the subhyaloid hemorrhage, then truncate the cone, then take the rest of the cone posteriorly, and that's the small bit of fibrous tissue at the disc which is removed, and surgery is complete after laser photocoagulation. Pearl number 7, so induction of posterior vitreous detachment is different. Here what we see is a macular hole on epiretinal membrane. We just go there, do a core vitrectomy, hold the vitreous at the disc, peel it off, just pull it off, and then cut the vitreous and do it. But on the other side, you see a proliferative diabetic retinopathy. We are not able to induce the posterior hyaloid separation, so you make an opening in the posterior hyaloid, then very gently tangentially peel everything. So and here you can see that there is a pull on the fovea, which is again tangentially being pulled so that we don't cause a bleeding or cause a break. And we see these little nodes. These are all NVE or fibrous tissue proliferation. You can see how we are not pulling off the hyaloid directly there. We're gently lifting it up and circumcising it, going around and making the fibrous tissue fall flat and then tangentially removing it. So that's how the induction of PVD is different. Though you would see people going ahead, holding it at the disc and pulling it off like how you do in a diabetic, in a macular disease, this is a much safer way of doing induction of PVD in diabetic disease. And pearl number 7, always look for a second membrane. So this is not the end of the proliferation, this is the end of the proliferation. So look for a second membrane and dissect underneath that decreases the risk of, you can see how it peels off. The second membrane, in a circumferential manner, if you peel it towards the fibrous tissue, all the vascular nails are exposed beautifully, so we are able to cut very easily, and the risk of an iatrogenic break as well as bleeding is much lesser if we operate under the second membrane. So here you can see that we are pretty much able to complete the surgery with the cutter itself, though I don't have a cutter fixation, but if you operate under the second membrane, we can pretty much remove all the fibrous tissue quite safely with this itself. Segmentation, delamination are old concepts. We don't separately do them. It's a continuous flow of the surgery now. So you could see that I peel the second membrane anteriorly, then now what we are doing is segmentation, now we are doing delamination. Earlier we used to do delamination with the scissors, but we are now delaminating with the cutter itself. All this is possible if we operate under the second membrane. Once again, you can see that is the second membrane, which is invisible, extending anteriorly from the fibrous tissue. So we move it towards the fibrous tissue, And now the retina is still bullous, so we drain the fluid, make the retina a little flatter, and then go ahead removing the fibrous tissue. So there are many ways to skin a cat. So some people start at the disc and then progress anteriorly. I usually prefer to do a truncation of the cone and then progress posteriorly. Here I am trying to induce the hyaloid separation. You can see the hyaloid is very, very densely attached and there's no separation at all. So then somewhere we made an opening and then we do a bimanual dissection. So if it's extensively adherent like this and there's no hyaloid separation at all, then I would jump in to do a bimanual surgery. So the forceps is being held in the left hand and the scissors in the right hand, but then we need to be reasonably ambidextrous. The forceps job is to just lift up to show us the vascular nail so that we are able to cut with the scissors and not to pull the fibrous tissue off. So here in this area, there is still no, inferiorly, there is still no hyaloid separation anteriorly. So that once again, very, very gently, we lift it up, identifying all the vascular nails and then removing it. And that's the last bit of the tissue at the disc, and we've removed it. Now we identify the break, do a fluid air exchange, reattach the retina, and do laser photocoagulation. That will be the end of the surgery. So as I mentioned, I usually do surgery from outside in, but here there is no separation at all. Once again, there is absolutely no hyaloid separation. So we open the funnel in the posterior pole. Even then what I do is once I pull the fibrous tissue at the posterior pole, doesn't mean that I completely pull it off and then I take it once again anteriorly, then come around back to the posterior pole. That's how I prefer to do the surgery, because posterior pole, you have sensitive structures like the disc and the macula, and you don't want to create a break there. And if it bleeds, once again, it bleeds massively in the posterior pole, making the surgery very, very difficult in these eyes. So I usually start peripherally. Outside in is what I prefer, but if I do inside out, once again, I start inside, go out, and then come back inside. So these are all combined retinal attachments. As you can see, this is the last bit of the fibrous tissue which is being removed. Reattach the retina with fluid air exchange, oil, and laser. And here, this is one extreme case, long-standing TRD, which became a CRD. It is a one-eyed patient and extremely ischemic retina, and we see extensive subretinal bands as well. So with very, very meticulous dissection, because one little bit more pull on the left hand, we will tear the retina, and this retina is going to be extremely difficult to reattach if we have a break. So now nearly about half the fibrous tissue across the retina has been removed. Rest of it is being very carefully removed, and that's the end of the surgery. We left this eye with PFCL initially. And what are the anatomical results? So traction retinal attachment, in about 95% of the patients, if we do the surgery properly, we'll be able to attach the retina, and vision improvement is in about 70% of the patients. Combined retinal attachment is a pre and post-op appearance of one of the patients. And eyes which look absolutely hopeless also do improve if the surgery is done properly. Complications can be cataract, retinitis hemorrhage, retinal attachment, anti-hyaloid proliferation, rubiosis, iritis, and neovascular glaucoma. To summarize, more one can see, more difficult the surgery. Extramacular traction retinal attachment can wait until it progresses or causes vision loss. Operating under the second membrane decreases the risk of breaks and hemorrhage. Need to create a roadmap for each case and then follow it up wherever possible. And if done properly, gratifying results are what we get in return. Thank you so much for your kind attention.
Thank you, Mahesh. It's a very enlightening presentation. I have seen all the indications which are definitely very common and very apt. Only one indication which interests me is vitreopapillary traction, which is not very common indication even among the VR surgeons. When do you say that I will go for surgery in vitreopapillary traction? And what are the signs that if you intervene, it will improve?
Initially itself, I will go ahead with the surgery if in case the disc margins are blurred in one eye and you see this obvious fibrous tissue which is pulling up on the retina. OCT helps as well. OCT can show that the disc substance is lifted up because of the fibrous tissue. If you are doubtful if that is what is causing it, then I would not intervene in the initial setting. So I will follow up this patient to see if these are the patients who don't have a macular reason for decrease in vision. If possibly, we can do a VEP, and then subsequently 3 months later repeat the VEP and then repeat the OCT to see if the vision is less, VEP is worse and the OCT worsens, then we operate.
Mainly the OCT around the disc.
Yes.
OCT around the disc, vision and during the follow-up, any deterioration.
Sure.
And no macular or peripheral lesions.
Correct. That's right.
Thank you very much for this. And we came to this end of this National Symposium on Diabetic Retinopathy, which is very, very common clinical challenge every ophthalmologist face. It is not retina specialist area at all. Every ophthalmologist has to tackle, and I thank each speaker who contributed immensely to this subject, and I thank Piyush for staying all around from AIOS, and a lot of promise he has. Thank you very much.
I'd also like to thank Dr. Ajit Babu Majji, past President AIOS and VRSI, for taking up the mantle of being the chairman. Thank you very much to all the speakers. We were extremely lucky to have the president, the honorary secretary, and as the scientific chair of VRSI in the session, along with other organizational leaders and researchers. So thank you very much.
Can we have a group photo?
Can we have a group photo with the speakers, please?